Good morning, good afternoon, good evening, wherever you're joining this webinar from. Welcome to the webinar. I know that it'll be different times and hopefully you're able to stay for the hour. Our discussion today is on practical approaches for community-based mental health. And we've got some expert speakers, but we'll wait a few minutes while people are still joining us before we start. Again, thanks for joining us. We're still waiting for another minute before we start, and there'll be a few more people joining us. We might make a start. Good evening, good morning, good afternoon again to all of you, wherever you are joining us from. We'd love to be able to interact with you during the webinar, and hopefully we'll have some questions that you want to share with us towards the end. For today's discussions on practical approaches for community-based mental health. I'm Nathan Grills. I'm moderating the session today. I'd like to begin by thanking CBM Global Disability Inclusion and the Arukah Network for co-sponsoring this webinar with CCIH. We've got an expert panel. I'm looking forward to hearing the discussion. If you're new to CCIH, it's an international network of approximately 115 organisations and 15 secular partners, as well as a few hundred individual members. CCIH's mission is to promote health and wholeness from a Christian perspective, and it provides opportunities for capacity building, networking, sharing, and sharing of best practices and advocacy. I've been a member, I think, since the last 15 years, and I've really benefited from a lot of CCIH's materials and networking events. So today's webinar, we'll hear from each of the speakers briefly, and then we'll have time for some questions at the end of, after the speakers have given their thoughts on a couple of questions I'll be asking them. Please use the Q&A box on the Zoom to type in your questions, and we'll answer those after the speakers have had a short chance to answer some questions that I'll pose to them. Hopefully we'll get through all the questions, but if not, we will endeavour offline or after to answer them, and they'll be included in the YouTube video at the end. So the webinar has been recorded and will be posted on the CCIH YouTube channel and linked to the mental health section under resources on the CCIH website, which is www.ccih.org. I'll start by introducing the four speakers. I think a lot of them will be known to you, I'm sure. I'm Nathan Grills, as I've already said. I'm a public health physician at the University of Melbourne, and I work on non-communicable diseases, community health, disability, and mental health, largely in the Indian context. I've worked with the Duncan cluster, which is part of the Arukah network, and it's a network. The Duncan cluster of the Arukah network is about 50 organisational members that work together. I work practically in disability as well, and I've been a friend of CCIH for 15 years, and our work is focused on looking at the role of faith-based organisations in responding to community health and development issues. Dr. Ted Lancaster is co-leader of the Arukah network and an early pioneer in community health. He's a co-author of and editor of the 2019 book, Setting Up Community Health and Development Programs in Low and Middle Income Settings, which is published by Oxford University Press year before last. Ted's also a friend, a mentor and a guru I've known and benefited from his advice for many years. And I think you always come away from any meeting with Ted feeling encouraged and blessed. He's trained as a family doctor in the UK and then spent 7 years working in rural North India in the remote Himalayas. He's also a founding member of Thrive Worldwide. And prior to that, he founded InterHealth, which is an organisation dedicated to providing healthcare, travel medicine and psychosocial support to missionaries and humanitarian workers. Julian Eaton is a mental health director for CBM Global Disability and Inclusion and assistant professor at the Centre for Global Mental Health at the London School of Hygiene and Tropical Medicine. He's a psychiatrist focused on public health, and his work involves promoting greater access to healthcare services, social inclusion and realisation of rights for people with mental illnesses and psychosocial disabilities. He recently returned to London after living and working in West Africa for 15 happy years, initially in Nigeria and then more recently in Togo. I'm trying to be brief for these introductions because there's so much more to be said about everybody. I don't want to leave a lot of time for discussion so you can actually hear from them rather than just the introductions. Joshua Duncan is joining us from Freetown today. He's the Program Manager for the Mental Health Coalition of Sierra Leone. He has about 20 years of teaching experience, 10 years in managing mental health programs and working with different actors, including the government of Sierra Leone, largely in mental health. He's been involved in helping the government with their services and structures and health system in regards to mental health. Prerna Singh is from Uttarakhand, from North India, and she works with community health and development programs. She's a consultant for training and program development, especially on disability and mental health with the Emmanuel Hospital Association, and has various other roles that she takes on. Most of her work is with children and young people in marginalised communities, and she's involved with research work on mental illness and disability. She also has a personal experience as a caregiver for people with mental health issues, and has been passionate for working in this area for a very long time, and I've been blessed to work with Prerna in research and in mental health programs. So we'll go look at the theme now. I wanted to start by asking a few questions of the presenters, and then we'll open it up for Q&A. So it's a theme, I guess, that many of us have a lot of experience in. I'd love to hear from your personal experiences, but that won't be possible during this webinar. But looking at practical approaches for practical approaches for community-based mental health. So I want to ask the presenters to keep it quite practical so that we can learn from each other. I might start with asking Ted a question. Ted, Setting Up Community Health and Development Programs is a book that's just been published by OUP. It's into its 3rd or 4th edition. I guess, why did you write the book originally, and why has the chapter on mental health been added to the latest edition? I know in the initial editions it wasn't a focus of the book, but it is the focus of this book, and there's a chapter in there. Yeah, tell us a bit about the book and why this chapter on mental health.
Thank you very much, Nathan, and hello to everyone on this call. Yes, well, I was working in the Indian Himalayas for a number of years, and there was no effective healthcare or facility in the villages. And the health team I worked with for those 7 years tried to model a way in which the community itself could come together, identify problems, suggest solutions, and then work together with our health team. And we spent days and weeks listening, holding late evening meetings in the mountain villages, which were magical and wonderful, and eventually training up to 60 village health workers, which the villagers selected themselves. And it was really wonderful to see how a community approach started to make a difference, both preventing ill health, treating dangerous illnesses immediately, such as malaria and pneumonia, through medicines in the VHW's health kits, but above all, engaging in ways to deal with the causes, the social determinants of ill health. For example, malnutrition was a crucial problem. In one group of villages, we measured 30% of under fives with severe malnutrition, and that reduced to just 2 children after 2 years after the VHWs went from house to teach about eating appropriate foods for each age group. So after 7 years, I realized we'd hit on some secrets, many of which, of course, we heard and learned about from programs in other parts of the world. And at this time, we were in the middle of a very exciting health movement. It was called the Health for All movement. We, to some extent, have something similar today, but it was very magical in those days. Health of the people, by the people, for the people, which is still my mantra, I have to say. And I realized that this was a crucial way forwards for global health. And of course, many others were thinking the same. So I put together our first edition of the book with examples from many countries and found that it caused a lot of interest, much to my astonishment, and was adopted by the World Health Organization as one of their recommended books. And it was also translated into Hindi. Over the ensuing years, mental health has become even more important. And we now know that 30 to 40% at least of people worldwide have suffered at some stage in their life from mental illness. And subsequently, I have realized even more than I did then that many of the physical problems that people presented with had psychological causes. The classic one, which some of you may be able to identify with, is what I call "and here's" syndrome. I have got pain here in my head. I have got pain here in my leg. I got pain here in my stomach. I've got pain all over my body. So looking back and looking forwards, I realized that in this latest and expanded edition of our book, the 4th edition, now co-edited by Nathan, that mental health is given strong and careful prominence and is the chapter I would most recommend, which Julian will shortly be talking about as the author of it. Thank you.
Thanks, Ted. Yeah, that's something I've experienced too, and the similar model, I think, of having community health workers, playing a role in mental health, and they do that. We've seen that through our programs, and you have, and something that I think has been picked up now quite widely. Julian, maybe it'd be good to hear a bit about the chapter that you authored for the book on mental health, and yeah, particularly, maybe tell us about general principles of how people in communities can be supported by good mental health services, even in poor communities where resources don't exist to have a level of psychiatric support.
Thanks, Nathan, and thanks for the invitation to participate. I really appreciate what Ted said about the way that mental health really became obvious as something that had to be included in this latest edition. And that's really a reflection of what's happening the world over in public health, where historically mental health was not really recognized either as a global concern or in many cases in families and in communities around the world. And that's really changed. And that's, I would say, the first thing that we need to do if we're going to start supporting people with mental health problems in communities is to acknowledge that this is an issue which has historically been taboo. People haven't really been wanting to talk about. It's associated either with a kind of spiritual blaming of someone or of weakness. And that's really the first thing that we need to make sure that the community is more accepting and responsive to the needs of people who have mental health problems. You also, of course, need to recognize that some people will need a type of professional care that they might seek for any other health problem. And that's the thing about mental health, that it's really a huge continuum of needs, from the kind of distress that you might get support from your neighbors or your family to really help you in a difficult situation, right through to very profound and severe mental illnesses that definitely need a degree of specialist support and sometimes hospital care. And so the biggest challenge really for thinking about practical ways for making sure mental health care can be available in communities, even in more rural places, is about making sure that people can access the right level of care for their need. And from that, very much community-based support of people around you, or even self-care, the next step is usually a skill set among the first-line community-based health workers or primary care workers. And we've done a huge amount of work in the last 20 years to really put the tools in the hands of those people to be able to really support them, the people who come to them who have mental health problems. And then the next thing, as is often the case with these systems in a kind of stepped care approach, is to say, well, where do those primary care workers seek support when they are no longer able to deal with the complexity of a particular person they might have before them? So linking up to good regional or even sometimes national hospitals where there are people with more skills in mental health, more specialist skills in mental health. So I think we've really progressed enormously in what types of skills that people need, and that usually crosses this range. And I talk about this in the chapter, from not only the kind of medical approach that we've historically really focused on, especially in high-income countries, but recognizing how important it is to provide social support and a loving and compassionate environment, and also the kind of important skills of talking therapies, of psychological interventions that can also often, in many cases, are the right treatment before, in some cases, of course, medication is also a helpful intervention. So a range of different types of support for people who are in different places.
Thanks, Julian. I know you have a lot of practical experience too, and we'll hear from some of the sites that you've worked in and from Joshua in a minute, and also from Perenna. But Ted, I'll come back to you just quickly to ask you more about the book. I guess it's hard to ignore the fact that we're in the middle of a pandemic, and I wonder what insights does the book give us into a response to the pandemic from a community point of view, but also the focus on mental health, and how does it inform our response, or how might it inform our response in the face of a pandemic and the mental health issues that are obviously associated with that.
Thanks very much, Nathan. Well, yes, of course, we're all right in the midst of COVID, and probably many of us would prefer not to talk about it, but I guess it is the relevant thing for the moment. It's interesting that Richard Horton, who's the editor of The Lancet, wrote a few months ago as follows: "This pandemic is dismantling the foundations for protecting and advancing health. Global health has entered a period of rapid reversal. De-development is the new norm." I found that a very frightening concept, and realized that the more I looked into it, the more that's actually true, that the impact of COVID has actually set back virtually all aspects of global health, is continuing to do so, sometimes by years. Non-communicable diseases have been neglected, so have childhood immunizations, maternal and child health, and so forth. And of course, health systems have been severely weakened in many areas. So in many communities worldwide, people are starting to restart or reimagine how an effective health program can be reset up or altered or brought more up to date. And the relevance of the book has suddenly been amplified as a result. So all the chapters remain very topical in our COVID and hopefully post-COVID world. And of course, mental health in particular has hugely magnified all the suffering of people in this pandemic, the sheer number of people struggling with issues, and the depth also to which they, their families, their neighborhoods, their whole communities are affected. So this chapter, Julian's chapter on mental health, stands out as being of special relevance for the current situation. And of course, we hope as many people as possible will actually buy the book, which is the most effective way of using it. It's also good to know that actually the whole book and each chapter can be downloaded free. And for many people, the chapter on mental health will be, I would recommend, one of the very first chapters that they would want to consult. Thank you.
Thank you, Ted. I might turn to some of our speakers that are currently based in low middle income settings, to Perenna and Joshua. Perenna, I might start with you if that's okay. I know you've used a lot of tools in your response to psychosocial disability in your area, and you have a number of experiences in the research space, but also in the training programs and developing tools to respond to mental health. So maybe you're going to share us some more information about some of what you've seen, or a case study of how those tools have worked.
Thank you, Nathan, and hello, everyone. In the community-based mental health program, we're using different tools, but one of the tools that I would like to share with you today is a youth-based, peer-based youth group curriculum. So it's called Nai Disha, which is a Hindi word, which means new direction. So this is a 18 weeks curriculum that is done with adolescents, with young people. And the main aim of the curriculum is to build resilience and promote mental health and mental well-being in the community. And it starts with a set of modules that just relate to oneself, like knowing myself better, building self-esteem, setting goals in life, to moving on to more social skills about like how to communicate effectively, how to communicate with your parents, how to maintain relationships for life, how to stand up against bullying, then again, further the modules lead into sexual and reproductive health and gender-based violence. So it's a whole curriculum of 18 weeks. And we've started with this curriculum it's almost 6 years now. And the changes that we've seen in the participants of the community, the young people, was like increased confidence, better communication skills, newer opportunities for some people. Some people got back to their work. Some participants were able to like restart their studies after setting up a smaller or bigger goals for themselves. And also a newfound trust and respect in the communities where these young participants were living. So we've done this curriculum mostly with communities who are marginalized, like migrants, brick-in workers, some minority communities. So these were the results that we saw. And I would like to share a small case study of one of the first group that we held. One of our participants was a girl called Brahmi. She's 18 years old. And she comes from Bhakra community, a community where the girls are not allowed for further, like higher education. They are only attend primary schooling, and that too only few of the girls are allowed. And the situation where they cannot even go to the neighbor's house, that's a very close community. So when we started working with them there, and she is one of our first girl who completed the curriculum, and the impact that it had in her life was like, from being someone who was not even allowed to go out of her house, who didn't even knew who the next door neighbor is. So while this 3 to 4 months of attending the group, it gave her an opportunity and a platform to know herself better, to be more confident, and also to set more goals in life. And with that, today, like if I mention her journey over the 5-6 years, she started volunteering with the program. She started with the increased confidence and more of a communication skill. She was able to convince her parents to continue her education. She was able to convince her parents and families to allow her to like assist our teams in the field. So now she's one of the first girl from her community who is a graduate, and she acts as a role model in her community, and she's encouraging other girls to join the Nai Disha program. So, and she's also one of the biggest examples, because after seeing the changes in her life, even her brother, who was not interested in studies and other things, and his brother and other friends, they got together, they requested the team to start some program for the boys also. So she was one of the key reasons why we also started a boys group in the same community. And so she's a perfect example of someone who went through the change and is now able to mobilize other people to join. And her goal for life is like, she wants to serve her community. And she says that whatever benefits she had from the Nai Disha curriculum, she also wants other girls and other youngsters in our community to learn that. And after volunteering now, after 6 years of journey, she's one of our community workers. She's a full-time employed community worker, and she's effectively working for promotion of mental health in our community. I would like to, there's a longer story. It's just a brief summary of how the program impacted. Yeah, thank you, Nathan.
Thank you, Prana, for that story. It's a really impacting one. It's one of many. We've been able to research a number of the areas where Nai Disha has been implemented. The University of Melbourne has been able to show, along with with Buran's program in North India, that the impact of Nai Disha is significant, and that's important to be able to show, rather than good case studies, but also good research, that this is a tool that does work. Brenna, is this being used outside India at all, the native shot tool?
We are in discussion right now, but it hasn't started yet. So I'm forgetting the name of the organization, but some organization in Bangladesh wants to adapt it. They're working on it.
I know we've also used it in schools and amongst people with disabilities and in different settings.
Yes.
We've been doing research on those different settings and how it has an impact in those settings. Yep. We might come back, and I'm sure people may have some questions about that tool and other tools that you have developed. I know that Burans has developed a number of tools. So if you have any questions, please type them in the Q&A function there, and we'll come back to those in a minute. There's already some questions there that I'm looking forward to answering, but I want to hear from Joshua first, and then we'll come back to those questions. Joshua, welcome. Thanks for joining us from Freetown. Can you please share with us your experience that you've had in Sierra Leone, both in health services, engaging with traditional and faith leaders and healers, but also engaging with the government? It'd be great to hear some of your experiences there.
Thank you. In Sierra Leone, we have 3 key facts around service delivery. And among these 3 key realities are, number 1, inadequate structures. And when we talk about structures, we're talking about the different layers of health, the PHUs, peripheral health units, secondary care, and tertiary care. It's so limited. And also, we also realize that our personnel are equally inadequate. The doctors we have are really not enough to cover all of these structures we have. And so sometimes we work with nurses and CHUs to man a whole center. And the third challenge around our structures or system is the inadequate equipment. And so in most cases, when you go to the hospital for tests, they would either tell you around typhoid or malaria. And there are cases when individuals will say this kind of condition, this kind of sickness has nothing to do with the hospital. So the obvious option are people turn again towards other service providers to look at what available service are there. And that is where the traditional leader healers and faith healers come into play. So by default, our system does not provide a lot around effective, modern kind of care for people with any condition. And so when we look around the issues around traditional and faith care, we realize that there are strengths, and I also realize a question around weaknesses. But people would go for unexplained condition to these institutions. And the traditional and faith healers who we have worked with, even in Sierra Leone, have their strengths and weaknesses. And what we have done as a coalition is to see how we could work in between to look at some key challenges and mitigate them. First, we know the traditional healers are the people that are reverenced and not necessarily their medicine. And so people believe in them. They believe that their deliverables are great, and so they respect them. It's the same for the church structure. They believe just this faith person, this faith healer, is able to bring a solution to my problem, so they go. Because the hospital says there is no medical thing discovered in this. The second thing is the fact that they believe that these people consult with the divine, with the supernatural. And so Africa constituting a lot of people who believes in the supernatural will turn to them. The third thing we realize, which is an advantage, is the issue around cash payment. 90% of income from Sierra Leone that are used for medical comes from out of pocket. And so when faith healers and traditional healers are able to give the alternative and are ready to take payments either in cash or in kind, and could be minimal for us in our context, or people value them a lot. But the last 2 points is that they are being treated within environments where they are familiar. And lastly, though not professional, people are allowed to visit them. So that brings the social cohesion around the service delivery, which our government could not provide as adequate as possible, or which our human resource needs from the area of medical cannot resonate with. But I would want to create the balance. Even though faith healers and traditional healers are able to do all of this, I would say there are some disadvantages which we really need to take note of. The one disadvantage we discovered during the Ebola crisis situation, they could not stop treating basically because it was their source of livelihood. So even when some of them were contracted by the Ebola and became ill, others still continue to do the treatment. The next thing that came out was that people want to know the reason behind their conditions. If it is not a hospital thing, then what's the cause? And somebody was referring to spirits and demons, and they really want to get answers to this. And so traditional and faith healers begins to produce those things that seem very supernatural, which eventually bring a lot of tussle among family members as to who is the cause for my predicament or my challenge. The third thing is their approach to care and the stigma attached. If people think you are a product or your condition or your sickness is as a result of demonic influence, then when you go out, others are being very careful of you. But if to beat the physical being is a means to get the demon out, then also that is huge abuse. And the other disadvantage on their end is because it is a livelihood need, they would bite more than they could chew. So they have more and service delivery, not evidence-based, and it's not total. What we do in Sierra Leone basically is to move away from the school of thought that we need to totally dissociate from them. Because honestly, if you dissociate, it does not solve the problem. Ignoring the problem is not a solution in any form. So what we look at is looking at places where we can collaborate and see how we could strengthen weaknesses. And we look at this from 3 points. First of all, we look at common comparable areas that we can work with, and we make sure that we bring them to some sessions and training. For example, our community health forums speaks around these things. What are the best humane and respectable way we can provide service? And so people learn to do what was not right in a better way. And the next thing is to tell them those things that does not produce respect for the people who receives the service or worsen their situation because you use approaches that are not best. We give them alternative. For us, if you want to distract, you should have the skill to attract. And lastly, what we do is to work with those who are not willing by bringing government policies and systems that will guide their action. As in the case of the moment, people are stopped from treating individuals because of the corona pandemic, and the agreement is always referred to the hospital, and if the hospital can't, which is always not the case, they would refer to them. And they feel very respected that we are the last port of call, and so when they turn to us, we could be the one that brings the solution, which actually does not happen. So these are some of the experiences we have in ensuring that service delivery does not only become an issue because of lack of human resource, but we also filter it down so that we would have some basic care and point out to effective referral pathways.
Thank you, Joshua. That's a really challenging area that you work in, and the insights you provided are really helpful. I'm sure everyone can identify with some of the stories that you've told as well. So thank you for sharing. I know you're doing a training today as well, so thank you for giving up your time during the training. What's the training you're doing today? Can I ask you, Joshua?
Okay, thank you. The work around mental health firstly carries a lot of stigma, and during the corona crisis, especially in our disclosure case, it really burns the people emotionally and mentally out. So our session today is basically geared towards empowering our team so as to be able to identify key pointers that might result to stressors, and also see how they could learn around self-care to increase their capacity to produce well. Because honestly, it's quite demanding. There is what we call this secondary trauma, which a lot of them haven't heard the story of people who are quarantined or who recovered, the issues around stigma all around them. How can you use the secondary trauma you are having to be able to manage yourself and able to give more of your work. That's the training we are having at the moment.
That's a fascinating area, Joshua, and I think, look, that's one of the questions that's come up in the chat session as well. We might open it up for the Q&A, and I'll come back to that, I think, and ask for the experience of others in terms of mental health and COVID. But if the presenters wanted to share, well, put your video on and stay muted until you speak, and then we can also have an open discussion around some of the questions that have been asked in the Q&A. If you want to ask another question, we have about 25 minutes or so to be able to discuss some of the questions. So please post your question in the Q&A chat function. But on that issue you bring up, Joshua, I think it's fascinating. It's horrifying, isn't it? I think that's what Ted also alluded to in terms of the huge mental health burden. There's a question about that, Ted, and is there any good research or sources that are demonstrating the mental health effects of COVID? So maybe just ask that question of you, Ted, and then also to ask Prerna and Julian also about your experiences of how COVID has impacted mental health in your settings. So I'll start with you, Ted.
I didn't quite catch the question you wanted me to answer. I'm so sorry.
Yeah, sure. No, there's a question from, where is it now? From Jim, just asking about the comments that you made about the impact of COVID on mental health, and any good sources of information about that.
I've just actually mentioned that and had a little discussion with Jim on that. So I think what I might do is, if this is all right with you, send some details, which I haven't actually got the sort of links, and send that on so that various people can actually look at some of the slightly more detailed background of what I was saying, if that's all right.
Yep, that's great. And maybe Prerna, can you tell us a bit more about your experiences during COVID, about how it's impacted people with mental health or exacerbated mental health issues, and also about how you've responded practically to those challenges?
Thank you, Nathan. Talking of COVID time, it was a mixed situation for us. Depending on some groups, like some especially the youngsters who we were constantly in touch with. For them, some of them, it was easier for them because they somehow knew how to manage stress and trying to find out a positive into a situation. That was something that we do as a group together. So for them, those kind of small strategies and techniques helped them. But it was very difficult for the team, I would say, the facilitators or the community workers, because we were not able to go to the field most of the time unless we managed to get a pass or a permission to go and work. But at that time, the people that we work with, people who had psychosocial disability and who either needed medication or who needed someone to visit them, like we're not able to do the home visit. So at that time, the situation worsened for those for the people in the community and also for the teammates, because they had to be on the phone. So adapting to from rather than meeting people and having a face-to-face conversation, and just trying to do it over the phone was a challenge that we faced a lot at that time. There were so much of stress and other issues that our team members ourselves faced. We were also trying to find out a strategy that would work, whatever that could help at that time. So I would say again, like Zoom definitely helped us, and WhatsApp call helped us. So it was more of work, like you could say that we are not going out and we are not going to work. We were not going to the work, but we were still working. So it was in more longer hours of work because the team had to listen to everyone who were having issues in the community. And then we as team leaders had another sessions every day where we had to just first listen to their queries and also trying to having discussions, team discussions, and to find out what could be the possible solution. And maybe just being, we appointed few people who were just there listening to everyone, because at that time everyone wanted to be listened and to be heard. So that was one of the strategies that helped the team. And in the communities where, especially in the rural context where the people were still not following social distancing and where they were able to move in the villages. So having the community workers and volunteers from the community helped, so that if the team worker or staff was not able to go there, the community volunteers, and also some Nai Disha group participants who attended the group maybe 2 years back or 3 years back. So those were the people that we knew in the community, and at this time they were given all the information about COVID and how to follow the right news and not to panic. So we used those people as agents who were able to help us spread the right information and to listen to people in the community. Yeah.
Thanks, Prerna. There's a lot of questions coming in, so I might just go to another question. Faith, thank you for your questions that you've asked. They're both very challenging ones. Julian, I might direct the first one at you, looking at the challenges of drugs as an increasing problem in the mental health space, especially amongst young people, and how have you seen people you work with handle that, or yourself, a new challenge of having to face the comorbid issue, I guess, of mental health and the use of drugs?
Yeah, I think as with many mental health problems, it's worth looking both at the symptom, what's actually happening in front of you with the person who you're trying to support, and also what's behind it. And I think this is often the case with communities that have been disrupted, or young people who are living in environments where there are a lot of stresses, maybe not many opportunities for them, maybe the economy is really very, very bad, because that's when you see more people turning to drugs. So it's often actually a symptom of a societal malaise, of a lack of hope and seeing opportunity in the future. So I think on the one hand, we of course need to respond to the person in front of us, and there are good ways that you can get alongside someone, help them to beat an addiction, and you know, lots of those are psychological counseling type techniques of helping people to be motivated to change their life and to stop using a drug. Sometimes there's a role for support with other medications and things. But I think more profoundly, we need to look at the opportunities that young people in our communities have, which is of course something that's going to be very challenged in the next decades, often because of the impact of COVID, which has hit young people really hard across the world. And I think that's partly where it's very important that we as health workers, as Christians, not only have that immediate engagement with the patient in front of us, but look at the way that society tends to cause these problems if it's not functioning well in terms of equity and people having opportunities that other people around them have. So I think the cry for justice and providing more opportunity for young people is at the heart of this, and that's something that's across all of society. But yes, mental health services and social services absolutely can and should include responses to support people who have found themselves with drug problems, and there are good evidence-based interventions that can do that. As I said, mainly around talking therapies, and sometimes for people who are not helped by that, more intensive interventions that sometimes involve more medical support, which should be a part of a comprehensive mental health service.
There's quite a few questions about the culturally appropriate nature of different interventions, both from Faith and also I think from Christine, a similar question. So I'll read Faith's and maybe open it up to the panel to see if you might want to try answering that one, which is an excellent question. But looking at she grew up in Africa, an evangelical environment where mental health is viewed as a demonic attack. I think many of you would identify with that as being a common understanding, and often that ends up seeing mental health issues mishandled. So what's the best way to balance and respond to the cultural, religious aspects and the mental health? How do we balance that out? Which also I think touches a little bit on the question that Christine asked as well. And can you comment on what's been effective in culturally appropriate ways? So I'll open up to the panel. I'm not sure who wants to tackle those very difficult questions.
Maybe I can just reflect back on something that Joshua said, which I think was very important, is that where there are very strong cultural beliefs around mental health, and that often involves a kind of spiritual dimension. And sometimes that can be very negative in blaming people, increasing the stigmatization of mental illness, and sometimes kind of including punishment as a kind of treatment. It's often also where people are seeking answers for why something's happening to them. So I think the big lesson learned over the time that we've been doing research in this area is that it's not helpful to set up a kind of us and them, pitting Western medicine against traditional approaches, because that's not helpful. And actually people value different ways of approaching common problems, largely interested in what works. And actually what we found, and Joshua has done lots of work in community mental health forums in Sierra Leone, of actually going into communities and starting conversations in a positive way about what's the common understanding around these problems, what can you contribute as traditional healers to people's well-being and healing, and where is the right time to refer, or where is the right time for a psychiatric nurse in a nearby clinic to also contribute, where maybe you think that this person isn't improving after a long period of trying, So we've certainly found that where people are given the right respect and acknowledged for their wisdom and the important role they play in their community, it's much easier to take things forward in a collaborative way. I don't want to sound naive, because it's also the case that it's people's income, and sometimes they resist the idea that a local clinic might take away their good paying patients. And sometimes people's human rights are being abused in prayer camps and in these treatment centres, and it's absolutely the case that we should also be standing against abuse. But I think we also need to be reflective about how much we know and how little we know about what works in those communities. And in many cases, a community response that involves the elders and leaders, for example, with the drug problems of young people that we talked about earlier, is often the most effective way of turning people's lives around or changing behaviors that are unhealthy. And we really need to acknowledge that. If a woman has come to your clinic because she's depressed on the surface, but actually it's because of a domestic violence situation at home, there's a community response that deals with that properly, not a medical one. And so we need to really be quite humble, I think, in recognizing the importance of those community leaders and community healers, including faith leaders, in order to give a much more balanced view of what actually transforms communities and people's lives beyond just medicine.
Joshua, I know you mentioned that's really helpful. Thank you, Julian. I know that Joshua also mentioned a number of approaches that during your talk. Do you want anything else, Joshua, to that question?
Yeah, I want to talk from the view of one who had an experience at certain points in my life, and somebody who is also a religious leader. The truth is, I have interplayed between all of those situations, and I'm also working in the community. The fact remains, what helps your recovery process is the community presence, is the people around you that love you and comes around you. And so ruling community out of effective service delivery is like taking part of the healing process of an individual. It's also from the view that if you trust the religious leader and anybody says anything else to you, it's hard to believe except it comes from the religious leader. And our goal in this case is basically, how can we then influence these religious leaders to be able to collaborate and do effective referral? Because the goal here is actually not who wins or who gives the best treatment. The goal is around the well-being of the individual that is sick and can return back to the community and contribute to its survival by the investment they can make as a result of the inclusion process. This is to be achieved only when we are able to see from the different fronts and are able to take positive, consultative, and collaborative action. Like Dr. Eaton mentioned, the forum, which has been very, very successful in our community, but also empower people through self-help group to be able to contribute and make the community realize that these people are not just dependents because they have this issue or a one-off episode. They can contribute to societal success by being involved in actions and activities. Let me just conclude by referring to one of the cases we had in our provinces. At the moment, because of the self-help group, now they have a big farm and they are cultivating it and doing crop production. And so we realize that they are moving away from being beggars or dependents to people who can fend for themselves and contribute to the needs in the community at Kwenadugu. So I am really moving and switching away from just blanket condemnation to empowerment for transformation so that service delivery could be total and holistic, and these people would go back into their community well and sound.
Thank you, Joshua. I might move on to the questions. One from Shameless Hamda. It's directed at myself and Prerna probably, but I might direct it to you, Prerna. Looking at the success stories from Naidisha and looking at how many people actually graduated from the course after 18 weeks and how long after completing the course was a follow-up mechanism measured. I guess we could also provide that Shameless with some access to some of the articles that have been published to help answer that. But Prerna, do you want to comment anything else on that?
Nathan will provide probably the articles that have been published. We've done 2 or 3 researches focusing on youth inclusion and also testing the tool, how effective it has been. So far more than 1,000 participants or members have completed the Naidisha over the course of 5 years, and we still have groups going on. And as per that question, there was also how many have remarkable changes, because the change or the impact varies from person to person, and also depending on the different communities and the social restrictions that these young people face. There are different levels of changes, and to measure, because we've done it as part of a research. So we always do a pre and a post test kind of. We do some questionnaires before beginning the group, and also after completion of the course. After the groups are finished, we do a post survey kind of thing. But for more follow-up mechanisms, because it's not just Naidisha, but we have other mental health programs going on in the area. We still continue to work in the same teams. So a lot of follow-up meetings and gatherings, say Youth Day celebration or some other, we keep getting back to the communities and calling those people together. So it's most of the changes are also being reported by the families, and also observations from the community workers who still work in those community. Have I answered it all? Or, yeah.
And I'll share some articles and publications that relate to some of that as well. But thank you for answering that, Prerna. A question there from Frank, which I might direct to Ted, if that's okay. Looking at community health workers or volunteers, and how do we maintain the motivation of those volunteers? How do we look at scaling that up? Should we be paying them? Is it sustainable to be paying volunteers? And how do we maintain their passion and motivation if we're not paying them? It's obviously a question that's you would have thought about a lot, Ted, and your members across the Arukah network would have thought a lot about as well. So I might direct that question to you.
Very much. You can't see me, I'm afraid, because I'm having a problem with my bandwidth, but I hope you can hear me. Yes, I think a really crucial thing is that the team and the leaders and friendly relationship with all the volunteers and the community health workers, so that they feel valued and honoured. You remember their birthdays. You remember to always affirm them in front of other people when they've done a good job. They're never told off or sort of reprimanded, if you like, in front of anybody else, and they are treated with the utmost dignity and respect. I think that's a really crucial thing. I think there needs to be a discussion with the community and with the government also about what is appropriate in terms of any financial arrangement. And of course, more and more community health programs are actually now government led, and many in Africa, of course, are also in part government funded. And sometimes it will be very helpful to fund, and sometimes it will be unhelpful if there's already, in particular, a very strong vocational sense or a sort of religious call. So I think it's really a matter of what we call in the UK horses for courses. In other words, you need to look at each situation differently and see what is appropriate there. But the one thing that is important is the honour and dignity and respect that is paid to all volunteers who are working with you. Thank you.
Thank you, Ted. And I note that all the Arukah networks across many countries in the world are all groups of volunteers coming together with that passion. So you have a lot of experience across the Arukah network. There's a question there from Henry Berry, which I think is excellent, which I might direct to Julian, given it's a bit more focused on particular responses to more serious mental health problems. So how do we address more serious mental health problems? Henry gives an example of a study from China looking at low-dose thorazine. Had impressive results, but is there any other progress on this front, Julian?
Yeah, it's a good question, because it's one of the questions that we're asking ourselves in global mental health. We've really focused largely in lots of the big trials on community approaches to common mental health problems, which by numbers constitute a huge global burden of disease and have therefore been a real priority for investment in research. But many of us are really interested in people with the severe, very, very disabling conditions, which often result in really appalling human rights abuses in many countries. And there hasn't been so much large-scale research for those groups, but most of it's focused around community-based rehabilitation type approaches, which you really need slightly more wraparound care, thinking much more about people's livelihoods and access to other services as well. Yes, directly to your question, there is good evidence that it's possible to integrate appropriate medical services, usually through evidence-based interventions like the WHO's MHGAP, for psychosis that can be treated by psychiatric nurses in primary care settings. But you also often need to think about the other things that make that person's life better. And that is often about housing or family reconciliation or nutrition and physical health and those kinds of things. You know, people with schizophrenia typically die 20 years younger than other people in communities, often because of physical health problems. So yes, there is good evidence. It can be done in primary care. The good thing is that the traditional, very cheap and more available antipsychotic medications are essentially as effective as the far more expensive modern ones that we've generally shifted to in high-income countries, although they have different side effect profiles. But they can be used really effectively in appropriate doses and minimize side effects.
Thank you, Julian. I'm sure if there's any other resources you might want to share, you can share that in the chat function, Julian. I'm sure would be helpful. I want to just go to a question I think is really gets us thinking about what we can do at a basic level of a church. The Pastor Davis asks, mental health issues in my church are not talked about and people are not aware of them much. What do we do to start in a church setting, getting people thinking about community health and starting to respond? What are the simple things we can do in that setting? Maybe Brenna and Joshua might be able to start.
With not just churches but any faith-based leader, from our experience, it was a challenge, because talking and sharing information about mental health and talking of mental illness, where in a platform where everything is being judged on the scale of right or wrong or sin or being holy, and the initial conversation was difficult. It takes time, but if we take the faith-based leaders as one of our main stakeholders in community, and so having regular meetings with them, sharing basic informations about what is mental health and what their role can be as the leaders, how effective their role can be in terms of being a listening ear to someone, in terms of guiding the youth of the church or guiding the youth of the community. So it depends, and you need to adapt to the particular group that we are talking with, like say in case we're talking to a Muslim leader, we need to change our approach at times. And also with the areas, the hilly terrain, which is more into demonic attack and spirits and karma and all those stuff, we need to adapt a different approach and different setting with them. But it works. Like we were not successful 100%, I would say. There are still challenges that we are facing, but we've seen a better approach. We've seen a better response from the church leaders in the cities that we work in, where they would contact, sometimes they would contact a community worker and say that, why don't you come and talk to someone in my church? They need to be, like they use the word counseling, but we say active listening and problem solving. So they say at times they invite us to talk to one of the youth or some member who's having a tough time. And also the support that we get sometimes is like they provide us a small space in the community, a room that we can use as a small, say, counseling center, things like that. So it works sometimes, but the challenges still remains.
For us, first of all, you cannot search for a cure without first, diagnosing what the condition is. Yeah, and so what we do normally is look at some of the symptoms. So, do you have headache? Do you have sleepless nights? When you have activities, are you a bit anxious around these activities? You do not look at the cause, you look at the symptoms. And then you identify people within the church who are skilled in some of these things, and you make sure you network with them and provide some session. For us, when you train within the culture, within the context, and by people with those symptoms, then it's better. We actually know issues around anxiety and the like are really not demonic. In most cases for us, they would think demonic cases are those who manifest certain kind of things. And you say, oh yes, these are in the spirit of A, B, and C. So you start from the point because honestly, anxiety, fear, and all of these for us in our culture, they are not considered as mental problems. They always look at worst case scenario. And at the moment, we are doing sessions for different religious institutions. And I want to, buttress on the previous speaker. What you look at is you focus on the area of needs. At the very moment, a church wouldn't provide 1 hour for a session of such. So we look at youth meetings, we look at women's meetings, we look at some of the gatherings. Can we just talk about how you cope with stressful situations? And in the process of teaching, which happened also in my church, people begin to identify with them, and you take them from the known to the unknown. And the impact is so great. And the feedback we have by means of testimony, because it was in my church, and somebody came out publicly to say, I had this problem, but when this training happened, I was able to identify and have different strategies of coping. It makes a lot of difference. So the individual in the church do a quick mapping process and see what are the needs and see what resource you have inside and how they can collaborate from also with others outside and provide the basic simple areas. You can move from the simple to the complex over time, but don't force to impose the change just at one go. It wouldn't work.
Thank you, Joshua, and thank you all of our speakers tonight. I really enjoyed the discussion. I'm sure if we could clap, everyone would join in thanking all the speakers. We're coming to the end right now of our time. I might just ask if any speakers want to make one final closing statement or sentence. They're all thinking on the spot. Ted's mouth's nearly open.
I suppose for me, it's a question of making sure that we start talking more about mental health as something that's a common experience of us all, and not excluding people as others because they have emotional problems. And I think that's the acceptance and recognition of a common humanity is probably at the core of most healing.
Thanks, Julian. Ted?
I would say that, in our communities, we need to, first of all, be very very careful to listen to what people are saying, and at the same time try as much as possible to accompany them in their journeys without exhausting ourselves by doing that with too many people.
Joshua, any final comments?
Yes, people can change, community stakeholders can change. And what we need to do is provide them the right information in a respectable way. And the attitude, behavior, and practice will follow.
Prerna, any final comments? And I might also ask you to close us in prayer at the end as well.
I would say one needs to have that passion, like accepting that the challenge that the other person is going through is no different from the ones that we face. So not just sympathizing, but empathy is something that needs to be in our hearts, the passion, and also the passion to share the love of Christ. Like how would have Christ treated someone should be our approach when we work with communities, and to be always there, like whether if it's just listening or just being there with a person. As Dr. Ted said, just being a part of their journey is something that will keep us going. So yeah, so that's my learning from my mental health work. So shall we pray?
Just say that we really hope you enjoyed the session today, and most of the questions we were able to get through, but we'll also include in the YouTube recording more answers to the questions underneath that. So if you want to revisit the session online, you can. CCIH would love to hear your thoughts about the webinar so they can continue to take on our feedback and improve their sessions. So there's a feedback link in the chat section there, and it'll also be emailed to you. If you're able to give them some feedback, that would be great. But thank you to CCIH, and thank you to CBM and to Arukah for co-sponsoring today's session. And I might end by asking you to pray for us, Brenna, and pray for those that we're all working with, and for those that are working in some very difficult situations right now. Thanks, Brenna.
Father, Lord, we thank you for this wonderful opportunity of learning and sharing that we got through this webinar. And we're thankful for all the fellow participants and attendees who attended this webinar and who were there in this journey of learning and sharing across different countries and different continents. We are thankful for the wide experience and knowledge that you've provided on the platform. And as we'll continue to work in different settings, in different roles and capacities in different areas of life, Lord, please lead us so that whatever we do, it may bring glory to your name. And as whatever learnings and experiences that you've given us, bless all of us with your grace, your wisdom, and the passion, Lord, so that whoever we come across, whoever we cross paths with, and with the communities that we work, Lord. So it's not just that we carry on with one particular topic, but we could be the ones who could provide them the holistic blessing, Lord, the holistic healing that comes from you, Lord. So as we come to the end of this webinar, we thank you for whatever was discussed, whatever was accomplished today, and help us now, Lord, to carry this knowledge and this information in our hearts, and may these discussions deeply impact our lives and our work and everyone that we connect with. In Jesus' name I pray. Amen.